Yeah, it's on.
Медичний департамент чи медичний казала?
Військово-медичний.
Військово-медичний департамент.
Where's the translator?
Доброго дня! Вітаю всіх на прес-брифінгу від гуманітарної ініціативи Світового конгресу українців «Захист патріотів». Ми завершили оцінку медичного департаменту Міністерства оборони України. Доктор Джон Квін і голова нашої ініціативи, директор гуманітарних ініціатив Уляна Супрун будуть представляти дану оцінку. Дякую всім за увагу.
Доброго дня, слава Україні! Міжнародна гуманітарна ініціатива Світового конгресу українців «Захист патріотів» розпочалася у травні 2014 року у відповідь на специфічну потребу навчити українських вояків надавати невідкладну першу допомогу під час бойових дій, а саме організувати і вчити курси бійця-рятувальника Combat Lifesaver і забезпечити IFAC – індивідуальну аптечку для першої допомоги кожного вояка, який пройшов курс. Програма фінансується за рахунок пожертвувань від українських громад з Австралії, Канади, США, Австрії, Чехії та багатьох інших країн світу. Захист патріотів забезпечує участь в навчаннях іноземних професійних інструкторів, сертифікованих за стандартами НАТО, та українських інструкторів, які є сертифіковані за програмами CLS і TCCC, які навчають військових надавати якісну першу допомогу під час бойових дій. Курси ідентичні з тими, які викладаються військовим НАТО та США і створені на основі навчальної програми, розробленої Інститутом професійного розвитку армії США. Вояків навчають надавати допомогу собі та своїм побратимам у межах їхньої основної місії, тобто їхнього бойового завдання. Наші курси пройшли вже 4500 українських вояків, і ми роздали майже 4000 аптечок. У рамках програми «Захист патріотів» Світовий конгрес українців запросив в Україну медичного експерта доктора Джона Квіна з ціллю зрозуміти основні проблеми медичної підтримки солдатів та добровольців, задіяних в антитерористичній операції. Проте ми не збираємося лише вказувати на проблеми, ми пропонуємо рішення для них, які успішно працюють в передових арміях світу. Слово передаю доктору Квіну, який завершив свою оцінку стану медичного апарату Міністерства оборони України. Dr. Quinn?
Thank you. Good afternoon, journalists, colleagues, military families, and especially the Ukrainian warfighter in the field. My name is Dr. John Quinn. I've been working in emergency medicine for over 15 years in Ireland, the UK, and the US, and I've been performing medical and health assessments in conflict and post-conflict areas like Iraq, Kurdistan, Timor-Leste, and Palestine. 2 months ago, I was asked by the Ukrainian World Congress to carry out such a medical assessment to highlight the medical care rendered to the Ukrainian warfighters from point of injury to definitive care. Ukraine has undergone a social and political revolution with great violence. Presently, there is an active anti-terrorist operation with a determined enemy that is armed with myriad lethal weapon systems and military power. This snapshot assessment was short, and a comprehensive medical audit with quantitative data collection and process observation will be needed in the future by the Ministry of Defense. There are shortcomings with the present emergency medical and evacuation process. The military warfighter, paramedic, and military doctor lacks standardized medical approach to emergency medicine, lacks the combat lifesaver training for all uniformed troops, and first aid kits, or individual first aid kits, IFACs. There is also a lack of combat paramedic programming. There are no purpose-built rotary wing medical evacuation aircraft currently in use. There are inadequate mobile military medical hospitals with deficient capabilities. Our colleagues at the Ukrainian World Congress and Patriot Defense with Dr. Ulana Suprun have already issued, by support of donations, over 3,600 IFAKs, or individual first aid kits, for the warfighter, with associated combat life-saving training for almost 4,500 soldiers under lead instructor Patriot, with over 20 years' experience, and many other volunteer instructors currently in the field. But this is only a drop in the bucket of need for the many warfighters that still have nothing and are fighting every day. There is a new collaboration between Patriot Defense and Victor and Oleh Pinchuk that has helped continue the expand the advanced paramedic training program currently underway, that is starting this weekend with warfighters in the East. Much work needs to be done. I'd like to take some time to show you some photographs of some of the elements that I had under the assessment. You can see here a Soviet-era tourniquet being used for a Grad missile attack. There is an airway issue and there is a catastrophic bleeding issue. Patriot Defense has students that are now warfighters in the field. This is one of them, rendering care to his combat buddy. There is a self-aid and there is buddy aid. Now, this tourniquet was inadequate. You can see the combat lifesaver is checking for a pulse, and there still is a pulse, and there is still active bleeding. The next slide shows taking care of the airway, but more importantly, the combat applied tourniquet. And you can see the combat lifesaver on the top of the screen with a combat tourniquet from an IFAK. This warfighter has training, and this warfighter has access to an IFAK. Now, there are only 3,600 currently in the field. There are anywhere between 6,000 and 14,000 uniformed warfighters presently serving. This is a classic example of the mechanisms of injury that take place in the ATO on a daily, sometimes hourly basis. And this is what happens when you have good training and you have access to IFAKs, resources in the field. This is saving life, and this is saving limb. This is a 1983 German donation ambulance. This is currently in use in Kharkiv, into Izum and possibly the ATO. This has, you can see on the inside, this is where warfighters are taken and transported. There is a lack of emergency medical equipment and emergency evacuation equipment. There is no heating in this ambulance. The range for fuel use is very poor, and this is currently in use. I should also comment that there is a few modern civilian ambulances in use as well, and those were also assessed. But this is currently one of the lead vehicles in use in Kharkiv. This is one of the civilian vehicles that is in use. This is currently in Izum. Izum has turned into a de facto receiving medical facility for trauma victims from the ATO, anywhere from 10 to 15 to 30 in a given day. And the surgical capabilities in Izum are completely overwhelmed, under-resourced, and absolutely inadequate. Inside the triage facility at Izum, where 10, 15, upwards of 30 warfighters will come on a daily basis during active engagement in late July and early August, this was the triage hygiene facility. There's significant problems with running water as well in the wintertime. This is the other side of the triage facility. If there is a warfighter that has significant injury, this is where the injury will be washed off with normal tap water. There is another room adjacent with a nurse that receives patients coming in from the ATO, and this is the triage. This is the main point of entrance for all warfighters coming into hospital. Elsewhere in Dnipropetrovsk, the military hospital, the main military hospital and regional facility, has this as their anesthesia machine. This is a circa 1960s anesthesia machine currently in use for surgeries for all trauma victims. There is no C-arm radiology technology for peripheral injuries, which is very common with the Grad rocket systems as well as with sniper fire. There are other anesthesia equipment there, a bit smaller, slightly upgraded from the 1980s and early 90s that are all Soviet era, but this is still in use right now in theater. This is surgical theater. This is where a lot of the consultants come down from Kyiv to this military hospital in Dnipropetrovsk, and this is their surgical theater. They had 3 of them. 2 were in operation at the time. You can see some of the tile is chipping off the bottom. The lighting is very old and inadequate. A lot of the surgical facilities that they use are still in operation, but they're not to a standard. I should also comment here that the surgeons, the Ukrainian surgeons here, are highly skilled, highly trained, and they have very expansive surgical skills. However, they lack the resource to be able to carry out their mission on a daily basis. The ability to see multiple patients at this facility is also hindered because of these lack of resources. Moving further east, this is a mobile hospital. This is the 61st Mobile Hospital, currently has been moved outside of the southwest region of Donetsk. And this is the main receiving hospital for the ATO in the south. You can see here there is a lot of hay on the floor, on hard dirt floor. This is where the first major rain, and at any amount of cold or inclement weather, this will become completely unsustainable. You can see from the tent here the wrapping up of the window. This flaps in the wind. This has complete, there's no climatization available at this facility. This is the main hygiene facility before entering into the dining facility. You can see potable water in the center of the picture. You can also see the trough, where this is where everyone must wash their hands before going into the dining facility for food times. And you can also see the big barrel of water that is trucked in on a daily basis. At the first sight of any amount of cold weather, at the first sight of any amount of inclement weather, this will certainly become completely non-operational. This is potable water and running water is an issue at the mobile hospitals, a significant issue as well throughout the ATO for basic services and hygiene and prevention. You can see here there is a potable water filter. And because potable water is an issue when warfighters come in, some people have to sit there for a few hours and just prepare potable water systems for when the patients do come in, they have access to potable water. This is the first section of the main receiving resuscitation department in the field hospital. You can see the soft goods. The soft goods that are needed in resuscitation are inadequate and very deficient. Lighting is an issue. Access to power is intermittently an issue at this mobile hospital, and obviously climate and climatization is an issue. If you turn to the other side of the tent, you can see the picture on the right side of the slide here. This is the other side of the resuscitation. This is just a flat mat, hardboard. Patients come in and triage decisions are made. Now, this other photo, I'm terribly sorry that it's so dark, and I'm not sure if you can see that well. Lighting is an issue at the mobile hospital, but there are multiple bowls with water, and this is just outside of surgical theater. And because running water is such an issue, sterilization process and the surgeons scrubbing in is also carried out in this bowl process, as opposed to having access to sufficient running water. And if we just go and enter into the surgical theater, there are 2 beds in this surgical theater. There is 1 anesthesia machine. There is 1 anesthesiologist or anesthetist, and this is surgery. This is damage control surgery, and this is the surgical resource that is available in the ATO. Overwhelming majority of decision makers and leaders in Kyiv are under the impression during the assessment and in interviews that a lot of surgery, in fact, almost unlimited amount of surgery, are carried out at these mobile hospitals. The reality, due to the resources and the lack thereof, is that very, very little surgery can be carried out to an international standard at these mobile hospitals. The resources are lacking, the medical staff are lacking, and they are highly trained physicians, highly trained surgeons that do not have the resources to carry out their primary function. C-arm radiology, portable ultrasound technology, and portable anesthesia equipment are significantly lacking and completely inadequate. This picture is of the personal hygiene facility. This is the laundry facility, the shower, and some of the toilets. They have 1, They have 4 toilets and they have 1 shower, and they cannot distinguish between male and female. And laundry facilities. This may seem quite boring when looking at a medical assessment, but this is absolutely core and critical for the warfighter and for the medical professional and practitioner to be able to have access to personal hygiene, especially when working and being awake for 36 hours straight, receiving patients. This facility did receive about 65 to 100, sometimes 120 patients in a 24-hour period. This is a significant strain and shock to a mobile hospital that has this very limited capability and capacity. Inside the mobile hospital, we can see 2 types of radiology equipment. One you can see on the right, which is on the hay, and there's other water bottles next to it. This is wheeled into tents and used. And the one on the left is in a mobile surgical unit, and this is about 55 years old, still functioning, and it has very, very limited capabilities. If you move just outside the mobile hospital campus, this is you can see a light, a simple light sticking out of the bushes there. That light is used for nighttime operations. You can see another one just slightly in the distance. When the helicopters come in that are not purpose-built for medical evacuation, they come to a muddy field, a muddy pitch, and patients are offloaded quite awkwardly because they're not fit for purpose, and they're made for warfighting. They're not made for medical evacuation or transport of the ill or injured. The patients are then brought to this treatment category outside in the wide open. Physicians assess and reassess. In some cases, they do not have time to reevaluate patients that have already been labeled with a tourniquet or labeled as urgent or critical or walking wounded. They do not have time to reevaluate and reassess these patients, to reassess their injury and recategorize them. And then if the patients are then taken into tents where they are either receive surgical emergency surgical operations, or they're sent back onto the helicopter where they go to a larger receiving facility approximately 45 minutes away. They're then re-triaged. They are then put into a ground ambulance for anywhere between a 35 and a 45-minute drive to the receiving facility where they will receive definitive care. There are many delays and there are many elements of this process that slow access to definitive care for the warfighter. On the flight line of a rotary wing or fixed wing aircraft, civilian ambulances are often recruited for use. They wait for the ambulance for the air ambulance to come, whether it's a rotary wing, which is a helicopter, or whether it's fixed wing, which is a normal aircraft, and they're waiting for the patients to arrive. Due to lack of communication, due to only using mobile phones and no encrypted communication technology for the medical teams in the field or at command centers, they do not know how many patients there are. They very rarely get access to the amount of critically ill patients, and the doctors come normally in sandals and scrubs from the hospital. Unless it is an absolutely beautiful day, which it looks like it is here, this will be completely unsustainable, and there's no use of personal protective equipment, and there's really no standard approach for a rotary wing or fixed wing aircraft with patients. So, just to comment on some of the acute and immediate needs. Combat lifesaver training for all uniformed troops is absolutely a requirement, with a comprehensive combat paramedic program and standardized pre-hospital training for all doctors. The warfighter, paramedic, and military doctors lack a standardized medical approach to emergency medicine and evacuation. And rotary wing aircraft for medical evacuation with advanced communication equipment is absolutely an acute requirement and need. Now, the Oleh and Victor Pinchuk and Patriot Defense have already started with some of these programs. I was able to observe some of the combat lifesaver training that Patriot Defense has started in the previous months. This is a training facility. They're currently training with the combat lifesaver Tourniquet. You can see this is obviously rigorous training. It's normally a 4-day program, and in some cases for the warfighter, they've been putting it into a 2 and a 2.5-day program. And I was able to observe some of the training that they do. The culture of medicine is quite difficult in Ukraine, and it's very difficult to explain that a combat lifesaver to a NATO standard can indeed start an IV for a patient and start giving fluid to a patient who is grossly dehydrated and may have lost a lot of blood. Here you can see one of the volunteer instructors teaching one of the combat lifesavers from one of the units how to start an IV on his colleague. And this looks like it's in the back of an APC. This APC during training was probably running. It was probably very hot. It was dangerous conditions, but training in a training and controlled environment. And this is what some of the combat lifesaver training that currently is underway are experiencing. This is taken from a tent during the paramedic training program that Patriot Defense have started, and the Oleh and Victor Pinchuk have helped continue. This paramedic programming is a much more detailed approach to medicine, and this is something that is needed. The combat lifesaver can be a warfighter. They can help themselves, they can help their buddy, and a paramedic can provide definitive care and help with medical evacuation out of the ATO. Now, it's not all practical. Some of the observations that I had with the training was that a lot of it is indeed theoretical as well. There's no lecture hall that is needed. But the instructors are very good at being able to wall off a corner and start with the training of the theoretical components to this course, and then jump right into the practical. This course looks to be very, very robust, and it's only covering about 5% right now of uniformed warfighters in the field, and that number needs to be about 90 to 95%. So just to review from the assessment, there are 3,600 IFACs currently dispensed based out of Patriot Defense with associated combat lifesaver training, and they are spearheading a new paramedic program with support and collaboration of Victor and Elena Pinchuk, and the Ministry of Defense support is required with clear collaboration to make this program sustainable. Certainly this program is great and amazing, and it's offering a lot, but this is not sustainable on donations alone. I'd like to just, it says more support is certainly needed. I'd like to just conclude with some of the key findings. The average time from point of injury of a soldier to first medical contact is between 20 and 60 minutes. This needs to be reduced to immediate self-aid, buddy aid, combat lifesaver training. The average time from point of injury to field hospital with surgical capability is 8 to 18 hours. In some instances, this was 2 days for some of the units that were cut off. These numbers have lowered due to volunteer groups and transport throughout the ATO. Soft and durable surgical supplies in the ATO are inadequate for high patient volume, winter weather, and major multi-system trauma and mass casualty trauma. The rotary aircraft used for medical evacuation are dangerous. The contracting or procurement of new or used fit-for-purpose aircraft is absolute priority. Individual first aid kits with accompanied combat lifesaver training is roughly at 5% for uniformed troops. This needs to be between 90 and 95% for all warfighters in the field. There are no armored ambulance transport capabilities at present in the ATO. The contracting or procurement of new or used or making current in-use vehicles up-armored entirely is absolute priority. There are Ukrainian firms that can do this, and they are waiting for requests from the Ministry of Defense. Lastly, communicable diseases such as polio, gastrointestinal illness, and tetanus present a clear and present threat across the ATO and all of eastern Ukraine, with inadequate access to consistent basic services, hygiene, prevention, and vaccination. So in summary, the urgent requirements based on this assessment are combat lifesaver training for all uniformed and irregular warfighters, the continuation of a comprehensive and sustainable combat paramedic program and standardized pre-hospital training for all doctors, fit-for-purpose rotary wing medical evacuation aircraft or helicopters with medical evacuation equipment and advanced communication equipment, and finally, modern mobile medical capability. All materials have been made available on patriotdefense.org website, and we will now take questions.
Standard?
Certainly. The data is not readily available. All data that we collected is anecdotal, so by interviews of physicians. Now, it's almost impossible to say whether or not these were caused purely because of lack of resource. But most facilities that we saw said that their casualty rates are upwards of 35%, and that they are primarily due to ballistic trauma, grad rocket systems, and sniper fire. A majority that we saw in mid-July, so most of the patients that we interviewed we were in late July, they were injured in mid-July, were from sniper fire and grad rockets. Now, a lot of the contacts that we have made in the field have let us know that there is a bit of a change in the evolution of warfare throughout the ATO. And there are new weapon systems being deployed that are causing a lot more burns, a lot more traumatic air injuries, barotrauma, and a significant trauma with mortar fire. Now, this leads to a lot of blunt and ballistic trauma, penetrating trauma to the chest and thorax, and to the abdomen, as well as to the periphery. When it comes to rate of one versus the other, it's very difficult to comment right now. We had anecdotal pictures at each of the facilities that we visited, and it came up to about 1,400 injuries. Burns, we saw about 35 to 36. However, that was people at the troops, warfighters at the burn hospital, presently taking care, under care when we were there visiting them. So whether they had received other multiple trauma and they were currently in surgery or needed surgical intervention, but also had burns, it's very difficult to categorize. When it comes to a NATO standard, it pales in comparison. It doesn't meet the criteria. Their resources don't meet the criteria. The logistical capabilities are near non-existent to an extent. Really, it's volunteers at this point that are evacuating warfighters out of the ATO. There is very limited capability at the Ministry of Defense right now, other than these not purpose-built aircraft that they're using. So I'm not sure if that answers your question, but the need for a quantitative process audit by the Ministry of Defense is acute. All the data that we collected was really anecdotal. You'd have to sit at the hospital and literally take tabulations. Most of the medical directors were very weary to give us any of that information. There was a very obstructive in nature, very obstructive, very unwilling to share a lot of that information, and most of them did not really have a whole lot of information other than when we were in Kyiv. One of the tertiary care facilities in Kyiv had access and was willing to share that information with us.
And another comment, we did invite a representative from the Ministry of Defense to appear with us at the press conference today, and he was unable to come. But the Ministry of Defense was made aware of this assessment, and they were given the full report prior to it becoming public and prior to the press conference.
Have they responded in any way?
Their response is that they agree that there are problems. They would like to continue, they would like to have a closer working relationship with the Patriot Defense Program. They will also be having a relationship with the second Paramedic Program through the Pinchuk Foundation and the Patriot Defense Program together. But other than those comments, they haven't had a response. We've created a working group with the Ministry of Defense. Patriot Defense has created a working group with the Ministry of Defense to start planning on handing the program over to the Ministry of Defense, the Combat Lifesaver Program and Paramedic Training Program, to the Ministry of Defense so that they will be able to prepare their own troops, their own medics in these programs. But it's in the very early stages. We simply signed an agreement that said that we will be creating a working group. We haven't even met with them yet. However, we do get, I can tell you, hundreds, if not thousands, of requests for our training every day, because the troops in the field and their commanders, not only the Ministry of Defense troops, but the troops from the volunteer battalions, the troops from the SBU, from the Border Patrol, from the Ukrainian UDA, which is the Ukrainian State Security Services, they all, the National Guard, the militia, special forces, they've all come to us and asked for training, and we've trained all of them. So we haven't simply trained the Ministry of Defense troops. We've trained the 2nd Battalion of the, I'll say it in Ukrainian, the Другий батальйон Національної гвардії, Альфа Служби безпеки України, 3-й батальйон Національної гвардії, батальйон Донбас, 11-й батальйон територіальної оборони, батальйон Миротворець, Київ-2, десантники ЗСУ, 25-й батальйон, Українська державна охорона, батальйон Львів, Золоті Ворота, Добровольчий український корпус, прикордонники, 54-й розвідувальний батальйон, батальйон Північ, 5-й батальйон, окрема моторизована бригада, батальйон Луганськ-1, Айдар, Азов, 16-та окрема бригада армійської авіації, спецрозділ внутрішніх військ Барс, батальйон Чернігів, батальйон УДО Щит-1, 1-й батальйон Національної гвардії, тобто всі батальйони Національної гвардії, 24-та бригада спецпризначення, 8-й полк, 138-й полк, 140-й полк, 80-та бригада, and every day we train more and more troops.
I should also comment, one of the main findings from the assessment, after trying to deal with the medical administration and the Ministry of Defense in general, was that the medical administration and the Ministry of Defense need to broadcast a single voice, the humanitarian and medical requirements by donors and the international community to carry out their core mission. It's very difficult for donors to be able to receive so many thousands of requests and not be able to focus any of the energy or effort. Implementing a marketing strategy by the medical administration and Ministry of Defense that clearly defines their core, with evidence, their core, and through internal audit and data collection, their resource requirements and what is lacking and what is mission critical and what is mission essential and what they will actually do with some of these assets. That is another core finding from the assessment, and that has not been made clear, and that is not a single voice right now from the medical administration or from the Ministry of Defense.
At this time, the Ministry of Defense is providing medical services for most of the soldiers that are in the ATO. So it is really through their medical services that most of the soldiers receive their care. That's why we focused on their specific medical services, even though many of the other ministries do have some sort of medical services associated with them. But the Ministry of Defense really has taken the lead on this. And with them taking the lead, they should also be the ones that take the responsibility of the status of their service and the responsibility of improving the services as they can.
I can also share with you the first aid kit that we saw with some of the warfighters, what they were given by the Ukrainian Ministry of Defense, by their higher-ups. Some had none, some had nothing when asked, what do you have? What do you have as medical equipment? Some had things that they brought from home, some had nothing, and some had this kit here. This is a very interesting first aid kit for a warfighter. It has very interesting materials. This is one of the bandages that are issued in it, and if you remember from the photo above, that it's quite a different mechanism of injury that this bandage will not be able to support or supply. The other things found in this kit were band-aids or plasters, and a tweezers and comb, and a condom, and a handful of other small devices that are completely inadequate for trauma. Now, the NATO standard, certainly the U.S. standard, is an improved or individual first aid kit. And this is what an IFAC is, this is what it looks like, and this is what it's capable of doing. The number one cause of death is from hemorrhagic shock, and bleeding out, patients that bleed out. And you can stop this with the combat gauze and with the Israeli dressing. Celox, which is very popular, is not to be used. That is through evidence. That is not evidence-based practice, and evidence-based medicine is not to be used anymore. The combat gauze is, and the Israeli dressing is, for major catastrophic bleeding. When it's in the periphery, what has to be used is the combat applied tourniquet, and this is the standard. The number needed to treat with this is 1. So if you use this, you will save life, you will save limb. This is what's needed to be used in the field. This is what is offered under the IFAC program with Patriot Defense, and this is what is required. It's not cheap, but if through government procurement you can bring the price down for these. This is a paramedic bag. You can see it's much larger than the IFAC. A lot of equipment inside of this paramedic bag can refill these IFACs for warfighters in the field. A paramedic can service anywhere between 10 and 25 troops maximum, and they need to be trained. There need to be 500 of these bags in the ATO with 500 highly trained paramedics and advanced practice paramedics. That is what is needed right now acutely. And for this, there needs to be at least one combat lifesaver IFAC for one warfighter soldier with associated training. And that is the standard that is required. And that is indeed the NATO standard, is to have an IFAC, you have combat lifesaver training, self-aid, buddy aid, and then you have advanced practice paramedic training with a paramedic giving you support, whether it's refilling your contents of your IFAC or whether it's giving your unit support directly. Are there any other questions? Okay, thank you.
Thank you. Дякую.
Yeah, Patrick sent him.